Good evening, everyone, and a warm welcome to this highly insightful webinar. I am Arpita from the IGCP group, and I will be your moderator for today's discussion. We are honored to have with us Dr. Abhiral Roy, sir, who is the System Director of Critical Care Services at CarePoint Hospital, USA, with us today. Sir is an esteemed critical care specialist with extensive experience in managing complex and challenging cases. In today's session, we will be discussing an very intrinsic topic, which is Neuro Lyme in disguise, a case of unexplained neuropathy and cognitive decline. It's often overlooked as a neurological culprit and present with vague and misleading symptoms, making early diagnosis and management critical. Dr. Roy will take us through a compelling case study shedding light on the diagnostic challenges and clinical approach to this condition. Without doing a further ado, I would now request Sir to please start with the topic for today. Over to you, Sir.
Thank you, Arpita. And thank you to everyone in the audience for listening to me. I'm going to present a not rare, an unusual case of unexplained neuropathy and cognitive decline in an elderly gentleman. And it is something to keep in mind, especially if you have a patient who's traveled abroad recently, especially to Northeast USA. So that would be anywhere in Boston, anywhere in New York, Boston, Philadelphia area, where these cases are common. Um, this becomes more important so because of increasing travel in our connected world. So something like this can present. So even though you don't see it commonly here in India, if you have somebody with the appropriate travel history, it is something to take into account. So we have a 75-year-old male who presents with acute onset of altered mental status, along with generalized weakness and dizziness. This has been going on for about 1 year or so, but has been getting worse in the last 3 weeks. Patient has a past medical history of hypertension, hyperlipidemia, that's high cholesterol, triglycerides, type 2 diabetes mellitus, as well as bladder cancer status post transurethral resection of the bladder tumor. He's also had a history of left nephrectomy for the same thing for the bladder cancer. Denies alcohol, smoking, or any illicit drug use. If his family history is non-contributory, he has no known drug allergies. The only travel history he has about 2 months ago, he went to Egypt, where as per the family, his cognitive decline and his weakness got worse over there. And once he came back to America, he never really improved or got better from there, which is why he came to us. In the emergency room on initial presentation, he was afebrile, tachycardic, blood pressure a little borderline, but otherwise respiratory rate was okay. Pulse oxygenation was 98%. He appears okay, no acute illness, maybe a little chronically ill, more than chronically ill, a little cachectic maybe. His eyes are open. He's not tracking to voice. The pupils are equally responsive and to light and accommodation. Has bilateral corneal reflexes. They're unable to assess range of motion since he doesn't really track, but he's able to look at both sides. And he has normal oculocephalic reflex. Mentation, he does not follow commands. Motor function, he withdraws to tactile stimuli, but no focal weakness noted, but again does not follow commands. On examination, head is atraumatic, normocephalic, normal inspection, eye exam appears normal. As per, he's able to move his eyes normally, but not just, but he doesn't follow any commands. Mucous membranes look normal, eyes, ears, nose, and throat looks okay. Neck exam appears to have a normal range of motion. A respiratory and cardiovascular exam is normal. GI shows normal bowel sounds, no abdominal tenderness. Apart from that, nothing much. Initial workup shows a normal white count, normal hemoglobin. CT scan was done, which is unremarkable. An MRI was done, which is unremarkable. Just age appropriate cerebral atrophy with extensive cerebral white matter, chronic microvascular changes, with chronic lacunar infarcts in bilateral basal ganglion. Chest X-ray was done, which is predominantly unremarkable. Maybe low volume chest X-ray, probably an expiratory film, but otherwise pretty unremarkable. Video EEG is done on initial presentation, which shows GPEDs are generalized periodic discharges with triphasic morphology. That is commonly seen in metabolic encephalopathy, rarely in toxic, more commonly in metabolic encephalopathy, more commonly hyperammonemia or uremia. Otherwise, non-specific diffuse and multifocal cerebral dysfunction, which means no focal localizing signs, but generalized slowing, maybe a lot of beta theta waves, loss of reactivity. But importantly, there were no seizures that were noted. Plan. CT was done, MRI was done. We wanted to do an LP. However, patient was too agitated, not following commands, so we weren't able to do the LP. He needed lorazepam 1 milligram IV to be given during the day because he's just so agitated, and nursing needed assistance in keeping him controlled. He was started on meningitis doses of antibiotics just because we weren't sure what was happening and because of his rapid cognitive decline. He was started on vancomycin, ceftriaxone, acyclovir, and ampicillin. Overnight, patient became increasingly agitated, was having some difficulty breathing. At around 6 in the morning, he was found to be in asystole with code blue was called. ROS was achieved after about 10 minutes. He received one dose of epinephrine and two doses of bicarbonate, and he was transferred to the ICU and intubated during the he was intubated during the code and transferred to the ICU subsequently. Over here, you can see post-code labs are basically unremarkable. Over here, you can see his. Give me a second. 1 second. Let me show you my laser pointer. So over here, you can see his chemistries. Basically, quite unremarkable. Maybe slightly high BU and creatinine, but nothing too bad. Liver function also appears to be normal. Slightly high alkaline phosphatase. We had checked his ammonia the previous day. That looked normal. We checked the ABG on him, and as you can see, the ABG looks unremarkable. This is oxygenation looks okay, pH looks okay, so PCO2 looks okay. So nothing that would really explain what happened. So we came. What's our differential diagnosis? Anoxic brain injury, toxic versus metabolic encephalopathy, stroke, delirium, hemorrhage. After the code blue, we went ahead and got another EEG. So diffuse generalized periodic epileptiform discharges, that's GPD, consistent with triphasics. Diffuse slowing with no normal wake or sleep features noted. So basically says no seizures. So that's gone. Also unlikely to be anoxic brain injury with that pattern. Highly likely to be toxic versus some sort of metabolic encephalopathy. Unlikely to be stroke because then you would see some sort of focal or localizing symptoms. And delirium normally will not have any acute EEG changes. So then we're working on what to do. He was intubated and sedated with propofol and fentanyl, titrating to achieve adequate comfort. We had family refusal of LP initially, so we were patients on acyclovir, vanco, ceftriaxone with acyclovir because concern for HSV. Repeat CT head was ordered, neuro was following, blood cultures, and all of that stuff was sent. And because it just recently coded, he was on vasopressor support with levofed, which is norepinephrine, and we were getting an echo on him. However, after he coded and he was paralyzed, and he was paralyzed and not paralyzed, but he was mechanical ventilation, family went ahead and gave us consent to get an LP, and we were able to get it. Over here, we can see an LP. We have some cells, not too many, 266, which is not bad, but we have a lot of WBCs, of which 91% lymphocytes. Correct? With a glucose level that's not too abnormal, LDH is slightly high. A total protein over here, if you see, is 300, which is quite high. And the CSF IgG to serum IgG level of 24.2, which is higher than what it should be. We also got a serum heavy metal screen done because of his cognitive decline. We are mainly looking for whole blood lead, mercury, and arsenic, and as you can see, those levels are quite normal. So if you look at our CSF, we have a high protein count, we have a high WBC count that is mainly lymphocytes. So looking at this, what do you think it could be? Our cell types are mainly lymphocytes, so it's not bacterial. It's probably either fungal or viral, or it could be TB as well. Our patient had normal glucose. If you can see over here, CSF glucose is normal, so it's not low. So unlikely to be fungal or TB. So we are thinking mostly viral. With we measure the opening pressure in this patient is normal. Increased lymphocytes definitely increase protein with normal glucose. With that finding, we then went ahead and sent an extensive meningitis panel, and that is when we came with the surprise that the patient had reactive IgG 41 and IgG 58, along with a Western blot that was positive. So then we had two tests that were positive for IgG Lyme's, sorry, IgM and IgG positive for Lyme's disease. So this was very very interesting to us. The rest of the workup was negative. We have hepatitis B negative, pneumonia and negative, Neisseria and meningitis negative, TB was negative. Other Lyme serology was the IgG Lyme serology was negative. However, the IgM was positive. So, given this picture, we made a diagnosis of neuro Lyme disease, which, as we know, is caused by the Borrelia burgdorferi. That's the name of the bacteria, which is transmitted by the isoxidase tick. Normally, it's also called the deer tick. Its natural reservoir is a mouse and has an intermediate reservoir of deer, common in the northeastern states, which is what basically where Boston, New York, Rochester, common in Toronto, Buffalo, what are other big cities? Philadelphia, most of New Jersey, most of New York, most of the area around Boston, most of Connecticut. You know where all your Ivy League colleges are located. That's where this is located, right? So that's the traditional what we call New England part of United States. So this is the typical bullseye rash that you see that is classical of Lyme disease. This is called erythema migrans, the typical bullseye rash, but it's only present like 30-40% of people. This is common stage 1. Stage 2 is called early disseminated disease. You can get lesions such as carditis. AV block is a more classical one that they'll ask you in your entrance exam questions. You can get facial nerve palsies, and you get migratory myalgia, basically muscle aches, and arthralgia, which is basically uh, joint aches. And then you progress to stage 3, which is called late disseminated disease, which can cause neuroencephalopathy, chronic arthritis, and peripheral neuropathy. And as we see, our patient had been having some sort of decline in symptoms for almost 1 year. So early localized within 30 days of exposure, you should only see the erythema migrans. You treat without serological confirmation. Weeks or months after exposure, you get a flu-like illness, multiple erythema migrans, heart conduction, cranial neuropathy, radicular neuropathy, lymphocytic meningitis is what our patient had. In the absence of erythema migrans, our patient did not have erythema migrans. We get a ELISA, which was positive. Then we got a Western blot, which is also positive, so we went ahead and treated. We gave our patient was already on ceftriaxone IV for the meningitis. So to this, we added some doxycycline as well. So our patient's course was complicated. Our patient had persistently poor GCS after his code, where he just refused to wake up. We repeated the EEG. We just showed diffuse slowing with very frequent triphasic waves, which to us was maybe a combination of anoxic state, post-anoxic from his code, as well as superimposed toxic metabolic encephalopathy. The reason we said toxic metabolic encephalopathy because this is something that he already had earlier. This ran for almost 96 hours of video EEG. We saw no change, with no major changes were seen. Also, but there was no epileptiform discharge or seizures seen, which means the anoxic brain injury was not so bad, which was causing, status epilepticus or refractory status epilepticus. To help improve the mental status of this patient, we went ahead and added a drug called modafinil, which is a neurostimulant. And this was to enhance cognitive function and accelerate recovery from disorders of consciousness. Its use is little limited We normally use it as a last ditch effort if a patient has been stopped on all sedation. We turn on the lights, we optimize everything. So their glucose is normal, they have no fevers, they have no chills, their infection is normal, their respiratory status is normalized, uh, their blood pressure is normal, cardiac function is normalized. After you do all these things, if they're still having trouble with consciousness, then you can consider giving something like modafinil. And yeah, so this was our final diagnosis. We suspect this patient had a case of neuro Lyme's that he coded when he probably got hypercapnic respiratory failure from basically having inadequate minute ventilation, and then when coded on the medical floor. We treated him. We After the LP, we came up with Neuro Lymes. He recovered significantly after we started the modafinil. He was opening his eyes spontaneously and looking at his children and looking towards family. However, because he needed to be trached and pegged, and he was transferred to a long-term facility for gradual weaning off from mechanical ventilation. Yeah, thank you.
Thank you, sir, for such an insightful presentation, I would say. Sir, if you're ready, shall we take the questions now?
Yeah,
Okay, sir. So I would request audiences to please share your queries. Meanwhile, I have received a few of them.
go
So
ahead.
the first question is, yes, sir. In cases where patients do not respond to standard antibiotic therapy, what alternative or adjunctive treatments that have shown promise in managing persistent neurological symptoms?
So the question is, if they're not responding to antibiotic therapy, have you investigated? Is it even an infection? Correct? Or is it a typical or is it atypical infection? Like, look at our patient. We started regular antibiotics, had no response, so we got the LP. We actually thought patient autoimmune meningitis, which is also a possibility, right? So, or you can have an atypical infection, like in this case, we had Lyme's disease, which came out positive. Now, in Lyme's disease, the classical antibiotics such as doxycycline, without the atypical coverage like doxycycline, may not work. We were giving ceftriaxone, but we added doxy. The other question is, have you done a full checkup to make sure it is not autoimmune meningitis or autoimmune what you call meningoencephalitis, where it could be some sort of autoimmune disease. The other one to rule out is paraneoplastic syndrome. A paraneoplastic syndrome is when it's a type of autoimmune meningoencephalitis, where you can often have which are said triggered due to an underlying cancer or underlying malignancy. So then you need to do that workup to ensure you're not missing one of those. So it invariably comes down to doing the lumbar puncture is essential, seeing what is the cell count. Is it neutrophil predominant? Is it lymphocyte predominant? What's the protein level? What's the glucose level? If it is an autoimmune disease, do you want to consider doing plasmapheresis and glucocorticoids? Because that's the next major question. Because then you have to commit to either this is an infection or this is autoimmune. Because they very, very rarely both. Because they're two different things. Antibiotic, you want maximal immune function, but if it's autoimmune, then you want to suppress the immune system function. So you have to make that diagnosis at least. Is this actually an infection or am I missing it?
Right, sir. So, sir's point is very clear and loud. First, get the diagnosis correct and then go on to the antibiotic therapy if required or not. Right, sir.
Agreed.
Thank you
Even if
so
you
much.
don't get the diagnosis absolutely spot on, like at least is this infection or not?
Right, sir. Absolutely. Thank you so much. Next question is, so considering the risk in tick-borne illnesses and the challenges in timely diagnosis, what measures should be taken to improve clinician awareness and early detection of neurolyme in endemic and non-endemic regions?
So luckily, India is a non-endemic region for Lyme disease, but there are other types of India is more common scrub typhus, right? In India, the disease which is tick-borne is classically scrub typhus. So again, you need to know what your endemic, what are high risk cases, but you should also have some awareness of where your patients have traveled. So one of them is if the patient is showing atypical symptoms, they don't seem to respond. Ask them to have a travel history. The travel history is important, right? Where have you traveled? Have you visited anywhere? Have you gone on vacation to Africa? Now with the Tanzania and Going to Africa has become common. So you should be aware of common African disease, yellow fever, some uncommon causes of meningitis. Then have they traveled to the US, United States, where the tick-borne disease like this, if you're going to the Northeast, it's tick-borne disease like this. If you're going to the center of the country, like the mountains of America, over there you get Rocky Mountain spotted fever tends to be common over there. So then you need to have at least a basic idea of common diseases in the areas where they have traveled. Or even if you don't need to know that, that is easily found online. The history is important. What is your travel history? Have you gone recently anywhere? And then based on that, search for the appropriate diseases.
Right, sir. Right, sir. Thank you. The next question is, how do you approach patient who continue to experience cognitive dysfunction and neuropathic pain even after completing the recommended course of antibiotics?
Good question. No, this is tough, and this is outpatient world. This question belongs in the outpatient world. So, or post treatment. Uh, Neurology is difficult. One of them is, now this our patient is 75-year-old. He had neuro Lymes plus he had a cardiac arrest also. We got him back in 10 minutes, but we don't know what his downtime was. Even though his CT and MRI never really showed uh, anoxic brain injury, he never really woke up. So that is difficult. So if they're unable to protect the airway, the trach peg, you have to put a trach peg. Counsel family, this is going to be a slow recovery. You normalize everything you can normalize: normal oxygen, normal glucose, normal blood pressure, normal body temperature. Avoid neurotoxic agents, so that means anything which can cause sedation, and maximize the sleep wake cycle. So make sure they're awake as much as possible in the day. Make sure they sleep well. Maybe give them medicines to ensure they're sleeping well. Do EEG, make sure they're not having seizures, no minor seizures. So optimize everything that you can, give it time, and that's all it is. We gave modafinil mainly as a something to as a stimulant to maximize their awake cycle, and there has been some weak data, nothing that is very strong, that shows giving modafinil or some sort of neurostimulant. Some people will even give caffeine from coffee, easily available. Just put it in their NG tube and see if that helps with their wakefulness cycle. But ensure that they're getting good quality sleep. Ensure at night they have minimal disruption, and then you just have to wait and rule out all things that you can treat and just wait for time for them to recover.
Right, so one more question has come. That is, given the overlap of symptoms, what key clinical and diagnostic markers help differentiate neurolyme from other neuropathic conditions like multiple sclerosis or early onset dementia?
This patient was too old for early onset dementia. He was 75. One. Two, in early onset dementia, you will get a frontotemporal cerebral atrophy, which we did not see on a CT scan. Uh, Three, we had CSF IgM positive for IgM and IgG both positive for Lyme disease. And we family history is common. Normally when you have early cognitive decline, there is testing that you can get done for it, and it's usually forgetfulness. This person wasn't so forgetful, more he was just more confused and disoriented and having weakness. Dementia classically won't cause weakness, so that was a big clue that this is something else.
Right, so one last question is the role of CSF and also PET-CT or MRI in confirming the diagnosis of neurolyme.
MRI may or may not show something. We MRI'd our patient at least 2 times. Both times the MRI showed no acute illness. Now, could this have been a vascular dementia? As per your previous question, it is possible, but vascular dementia is usually associated with multiple strokes. This patient had no history of strokes. On imaging, he had extensive ischemic small vessel chain disease, that is basically poor blood supply to the insides of the brain, and some lacunar infarct, but no clinical strokes. And he didn't have that stepwise decline that is normally associated with stroke. I'm sorry, what is the rest of the question? Yeah, PET CT.
Pet city, yes,
Pet,
sir.
PET CT is good when you have a focus of infection you can't find, right? So if you have an abscess, or you have an intramuscular abscess in the thigh that you can't see from the outside, or if you have you were looking for a small source, say a meningitis, so not meningitis, but say epidural abscess, or a small osteomyelitis, which is not showing up on CT, or not showing up on CT, regular CT. PET is an easy way to do a whole body scan. MRI will show infection, but the trouble is MRI, doing a whole body MRI is very, very difficult. It is more efficient to do a whole body PET CT, and that'll tell you what you need to find out. But in the brain, unless you have obvious inflammation, MRI encephalitis will show up on MRI, but a meningitis may not. At least not without contrast. And in our patient, we tried doing an MRI, he was just too agitated. So, as you could see the image, there's so much movement artifact, we decided it may not be possible to get it again.
All right, sir. So that was the last question, and with that, we would like to conclude today's webinar. But before that, sir, on behalf of the entire team of IGCP, I would sincerely thank you for your insightful presentation on this very crucial topic. And we truly appreciate the time and effort you have dedicated for making the presentation and for solving all the queries that have come from audience. Thank you. Thank you so much, sir.
Perfect.
And
Thank
thanks to
you.
everyone for joining and putting up their questions. Thank you.
Thank you.
Thank you so much, sir. We are concluding for today.
Thank you, everyone, for joining. Thanks.